My name is Richard Rosenquist. I'm at Karolinska Institutet in Stockholm, Sweden. So I was given the question, how can we select the best targeted therapies for patients with CLL? In my lecture, I discuss that we now have entered the precision medicine era also for our patients with CLL. And I argue that we are using precision diagnostics and also have precision therapies. And that is the novel targeted therapies. So if we look at the prognostic and or predictive markers that we are using in diagnostics of CLL patients, the first one that we have used for now many years is detection of recurrent chromosomal aberrations with prognostic impact, and that is deletion of 13q, 11q, 17p, and also trisomy 12. And we do this analysis by fluorescence in situ hybridization, FISH analysis. And we know in the chemoimmunotherapy era that patients with 17p deletion have a dismal outcome and do not respond well to chemoimmunotherapy. Instead, they should be considered for targeted therapies. Also, we know that patients that have or carry TP53 mutations, they also have a similar dismal outcome and a more aggressive clinical course, and they should also be considered for targeted therapies instead of chemoimmunotherapy. And TP53 sequencing, we now also perform for all patients with CLL, screening the entire TP53 gene. So before start of therapy, the recommendation is to perform FISH analysis of recurrent chromosomal aberrations and also TP53 mutation screening. Then the question is, do these hold as markers also now for targeted therapies? For TP53, we see that patients with such aberrations, at least in the relapse refractory situation, they still are poor risk markers. So for these patients, it has been recently shown or outlined in the ESMO guidelines that they should be given alternative treatments and not chemoimmunotherapy. If we turn to the IDH mutation status, this is a marker that we know since more than 20 years now that it's a strong prognostic marker. And it was now included in the latest iwCLL guidelines that this should be performed, this test should be performed on all patients with CLL. And we only need to do it once since the mutation status is stable. So what we can see with the IDH mutation status is that we can divide patients into two groups, IDH mutated CLL with an expected favorable outcome and IDH unmutated patient with a poor clinical outcome. They experience more aggressive clinical courses. So the IDH mutation status in the chemoimmunotherapy era, we know that patients with mutated immunoglobulin genes, they had a favorable outcome after FCR therapy. But perhaps even more importantly, with the targeted therapies, we see a dramatic effect for patients with unmutated immunoglobulin genes, both for BTK inhibitors and BCL2 inhibitors. So we can say that the IDH mutation status also have predictive impact and also impacts the clinical decision making. And also the IDH mutation status was included in the ESMO guidelines for selection of therapy. Finally, if we look at a complex karyotype, we know since the early 1990s that the more genomic aberrations or chromosomal aberrations, the worse outcome. And this was reinforced by the introduction of targeted therapies when it was observed that they constitute high-risk group. So there have been a debate if complex karyotype, how we should define it, how many aberrations, and in the larger study performed on more than 5,000 patients, they showed that patients with 5 or more aberrations, if they were P53 wild type, had, or they constituted a high-risk group. So 5 or more aberrations. And in a parallel study looking at genomic arrays, they also found that 5 or more aberrations were linked to poor outcome. We know, of course, with chemoimmunotherapy that that complex karyotype is linked to a worse outcome. So what about the targeted therapies? In the relapse refractory situation, complex karyotype is linked to a poor outcome. There is less data in treatment-naive patients if it matters or not, but in the relapse refractory setting, it is indeed a strong negative prognostic factor. And there was a recent paper from the US showing in patients treated with ibrutinib that there was a continuous increase in worse outcome if depending on the number of aberrations. So they suggested to use complex karyotype as a continuous variable. I think that we need more data, especially in treatment-naive patients, on the impact of complex karyotype in treatment-naive patients. And we also have to continue discussing what is the best way of measuring complex karyotype. Right now, 5 or more aberrations seem to be relevant, but we have also this suggestion to use a more continuous variable with sort of increasing number of aberrations.